welcome everyone to this WSO webinar, Stroke Care in Africa, Priorities, Research and What Next. It's now just gone 2 o'clock in the UK and in Ibadan in Nigeria, and 1 PM in Freetown, Sierra Leone, and 3 PM in Kigali, Rwanda. So my name's Sarah Belson and I'm the International Development Manager at the World Stroke Organisation. And it's my pleasure to host this webinar today, brought to you by the World Stroke Organisation and also StrokeConnector, the new online hub for World Stroke Organisation members. If you're on Twitter, the hashtag for WSO is @WorldStroke.org. The webinar will run for an hour and we are recording, and it will be available on the WSO website in the next few days. After the presentations, we'll have a Q&A session. Please post your questions for the panelists throughout the webinar. This helps us to manage the questions during the Q&A session. Please ensure that you post them in the Q&A function at the bottom of your screen rather than in the chat function. So we have a really interesting panel today of speakers. We have Dr. Rufus Akinyemi from Nigeria. We have a cohort from Sierra Leone, Dr. Dan Youkee, and the colleague Professor Radcliffe, and also joined by Professor Kath Sackley from King's College in London. And then from Rwanda, we have Dr. Gerard Urimubenshi, and we're mindful that there might be some connection issues from Rwanda. So we also have Gerard's colleague, Professor Jackie Bosch from McMaster University and the OSCAL programme, just in case she needs to step in. So our first speaker today is Dr. Rufus Akinyemi, who's going to introduce the recently established African Stroke Organisation and give us an overview of the stroke care context across Africa. Dr. Akinyemi is a neurophysician and a researcher. His clinical research and advocacy work centre on vascular and degenerative brain disorders. Dr. Akinyemi has a passion for collaborative work to improve brain health in Africa. This passion led him to establish a grassroots stroke initiative, the Abeokuta Stroke Foundation. He's currently serving as Secretary of the Nigerian Stroke Organisation, as well as a member of the steering committee of the WHO-WSO Lancet Commission on Stroke in Low and Middle Income Countries. He plays a leading role in the Siren-SIBS genomics study, and his FLARE research is exploring the genetic basis of cognitive dysfunction after stroke. Dr. Akinyemi is the Deputy Director of the Centre for Genomics and Precision Medicine at the University of Ibadan, where he's also a Senior Research Fellow in the Neuroscience and Aging Research Unit and a Consultant Neurologist to the University College Hospital, Ibadan. He holds fellowships in neurology and global brain health from institutions in Nigeria and Ireland, as well as a PhD from the University of Newcastle in the UK. So, Dr. Akinyemi, thank you so much for joining us today, and I'll hand over to you.
Thank you very much, Sarah, for that very brilliant introduction. And thank you for organizing this series of webinars. And again, thank you in particular for the focus on Africa today. Can you all see my screen? Can you see my screen? Right, great. Thank you very much. So I'm going to introduce to us the recently established African Stroke Organization and speak on the priorities for stroke care. But before I do that, I think it's jamming to briefly review the stroke landscape in Africa. As we all know, that stroke is a disease of global public health importance. Stroke indeed is the most common cause of adult neurodisabilities, second most common cause of death, and of course, a disease of such immense importance. And we know that from the recent global burden of disease study, that the lifetime risk of stroke is 1 in 4, meaning 1 out of every 4 living persons has a risk of stroke in the course of their lifetime. Several studies have been undertaken in Africa on stroke. Many of them, majority hospital-based and fewer community-based. And of course, these studies are of different degrees of quality, but in spite of all the challenges and difficulties, we do know that, as a matter of fact, and particularly from the stroke incidence study undertaken from High District of Tanzania, that estimates of stroke in Africa do report some of the highest rates globally. For instance, the incidence rate of 316 per 100,000 person years is the highest globally, suggesting that 6 Africans will come down with a stroke every minute. Prevalence also from the Niger Delta region of Nigeria gave a rate of 1,460 per 100,000 people. And case fatality rates as high up to 43% at 1 month and 84% at 3 years. This review, the burden of stroke in Africa undertaken by our group, is freely available online and may be consulted for further details on the burden of stroke in Africa. However, it's needful to make mention of this elegant work from the Aging Courts Rural District of South Africa, a paper written by Maretza et al. The highlight of this paper, I'd like you to know, is that when you consider disability adjusted life years lost due to stroke, the highest age adjusted rate is reported in the age bracket 45 to 59 years, which brings an important point that stroke in Africa strikes in the prime of life. And this, of course, has implications for individuals who are dependent on such a stroke patient. Beyond this, there are certain peculiarities I'd like to draw attention to regarding stroke in people of African ancestry. We do know from reviewing extant literature that stroke occurs at a relatively younger age, mostly mean age is about 60 years, which is much lower compared to 70s and 80s that we see in Caucasians in Europe and North America. African ancestral individuals have a relatively higher excess burden of hemorrhage, 34% versus 9%. This was from the interstroke study. And from meta-analysis of all African studies that we undertook and published recently, we found that there is a relatively higher burden of higher proportion of small vessel disease related stroke. And then from the SLES cohort from London, looking at the African ancestry sub-cohort, higher genetic disability was reported compared to European ancestry. And of course, looking at several studies, we do know of the fact that apart from mortality being higher, morbidity profiles are also worse in people of African ancestry after stroke. Of course, we may adduce this to socioeconomic factors, together factors, exposure to pollution, but there may also be some genetic basis for these worse outcomes, and these demands require further exploration. The dominant risk factors for stroke in Africa are hypertension, dyslipidemia, obesity. And the interstroke and siren studies have these overlapping findings. Again, poor diet low in vegetables, and physical inactivity are also risk factors. These are dominant risk factors for stroke in Africans, but hypertension actually accounts for population attributable risk that is as high as 90%. So it is the dominant risk factor for stroke in Africans. We also know that stroke awareness, knowledge of risk factors and symptoms of stroke is relatively poor from meta-analysis studies, from meta-analysis or systematic review of several studies done on the continent. And even among health workers, among hospital workers, stroke knowledge could also be poor, especially among non-clinical workers in the hospital. And we also know that there are influences of culture, beliefs, and faith on perception of stroke among Africans. And these reasons will account for late hospital presentation. From Ibadan, our colleague Obolia et al. Undertook a study of time to presentation in a sub-cohort of our soldiers in Ibadan. And he found that in that particular study, no patient presented within 3 hours of stroke onset. And the time of presentation was 24 hours. Of course, this is an indication that we need to do a lot more in terms of stroke awareness campaigns and raising stroke literacy in the population. Availability of diagnostic services is quite low in low and middle income countries, including those of sub-Saharan Africa. This slide shown from the Interstroke study and led in this paper, elegant paper led by a great friend and mentor, Peter Langerhorn, does show the poor availability of appropriate diagnostic tools in low and middle income countries, including those of South Africa. Could see that MRI, that of the subjects in the interstroke cohort, only 1% had MRI scan, 1% did have Holter monitoring, and 2% had carotid Doppler. Compare that to the proportion that you see in high-income countries. So it's an iceberg of the low availability of diagnostic resources in African countries. Beyond this, we also know that there is a challenge with stroke clinicians, stroke physicians, neurosurgeons, stroke nurses, occupational therapists, speech and language therapists, dietitians, and people who are trained to work in a multidisciplinary setting. In this paper that resulted from a survey undertaken about 4 or 5 years ago, you can see that if you compare Nigeria, for instance, to European countries like Norway or Poland, you see that despite having a lower population and having a relatively lower or similar stroke incidence estimates from the GBD study, you can see that the number of neurologists is relatively low compared to what you find in Norway or Poland. Even South Africa fares better, but of course doesn't even have enough neurologists as you find in European countries. And there are countries in Africa that have only one neurologist or even none at all. So this highlights the challenge and the need to build capacity and raise an army of stroke experts across the continent.
Left hand day. Pull eng.
Now, problems can become opportunities when the right people come together. Therefore, we're not scared of the challenges, of the huge challenges in Africa. Rather, we're inspired to seek avenues to overcome these challenges, to mitigate the barriers, and to strengthen the enablers of defeating stroke in the African continent. This philosophy was essentially what influenced the establishment, the conceptualization, and subsequent formation of the African Stroke Organization. The journey of the ASO formation is a journey of several years, but became accelerated in, I would say, in the last 3-4 years, when people of like minds met at meetings, conferences, also congresses, and of course, with encouragement, great encouragement from our friends in the World Stroke Organization, the leadership, Sarah Belson, the international development, international programs developer, and other great people encouraged us, and eventually were able to come together to establish the African Stroke Organization. The first document, communication to WSO leadership, was in 2016, but February this year, this paper was published, essentially placing the vision of the ASO in the public domain. The vision is very simple: to reduce the burden of stroke in Africa. Of course, this is in tandem with the vision of the World Stroke Organization, but rather Afrocentric, focusing on specific issues and needs of Africa. And to accomplish this vision, there's a mission to reduce the burden of stroke through multidisciplinary research and capacity building, promoting the development of hepatitis stroke prevention and intervention services, and of course, advocacy, and from promoting the formulation of stroke-friendly policies across policymakers across African nations. The vision, the mission of ASO is well featured, well represented in this artistic impression. We see that right at the center we have the continent with different colors of strands representing the neural network, and also representing the rich cultural, environmental, human, and of course genetic diversity that you have in Africa. And around that, you have a rim of people holding hands, sending the message that we will meet together, with inclusivity and diversity, inclusiveness and diversity, to form a strong force to roll back stroke from Africa. And the ASO has 4 major pillars: research, capacity building, advocacy, awareness and empowerment, and of course, development and improvement of stroke services. And why do you know this? ASO is people-centered, aims to working with partners, aims to change the face of practice, and of course, enhance policies that promote stroke on the continent. Currently, we have about 179 individuals who have expressed interest electronically to be members. And we have a governance structure that has a 15-member steering committee, 15-member board, and 5 working groups. And we're also developing professional interest areas. The formal inauguration would have been undertaken in the month of April at a leaders meeting, but this was hampered by the COVID-19 pandemic. However, ASO has a very active WhatsApp platform, and we're building membership database, building the ASO website, and of course, we're also working to register it formally. And we hope between 2021 to conduct an online survey to determine stroke priorities for Africa, run an ASO strategic leaders summit, and publish a document on strategic action plan for stroke in Africa and Vision 2030. And of course, also run a conference. The priorities, we have undertaking stroke services, review of stroke services in Africa, and challenges are shown in these slides: pre-hospital, hospital shares, stroke units, post-stroke care, and community support. And there are efforts to foster development of stroke unit services, building on the WSO framework, and of course, using telemedicine, mHealth, and of course, foster partnerships across different groups and North-South partnerships, foster service improvement, and then build capacity across the continent, and also promote advocacy that are already ongoing. In conclusion, WSO is people-focused, works with all partners to promote stroke-friendly policies, and positively impact the science and practice of stroke in Africa. Thank you very much.
Thank you, Rufus, for that really comprehensive overview of not only the burden of stroke in sub-Saharan Africa, but also the role and priorities of the Africa Stroke Organisation and where you see the next steps. And there'll be a chance for people to ask you questions in the Q&A session at the end. So please don't forget to post your question as we go along in the Q&A function at the bottom of your screen. And now over to our second speakers. So we have Dr. Dan Youkee from King's College, London. We also have Professor Radcliffe Lisk, a fellow of the West African College of Physicians, and Professor Kath Sackley, also from King's College, London. And they're going to talk about the Stroke in Sierra Leone project, give an introduction and an overview, talk through community engagement, the CISLE data, and the impact of COVID-19. So over to you all.
Yeah, so Stroke in Sierra Leone project is funded by the National Institute of Health Research, and it's a 3-year programme in partnership with an existing partner with Sierra Leone, the King's Sierra Leone Health Partnership. So this was funded about 18 months ago and is in conjunction with Peter Langhorne, who we've heard about already, UCLAN, and Tony Rudd from Guy's, Professor Radcliffe Lisk and Dr. Dean in Freetown. Can we have the next one? So National Institute for Health Research funds health services research. We're very glad to be part of, usually within the UK, but a new initiative to fund global health studies. So the aim of the NIHR is to be at the far end of the implementation pathway. So they're looking for studies that will aim to improve outcomes for patients within 5 years. And they fund a team of people with different skills and abilities. Thank you. Next one. We are really, the study has 5 parts, obviously the organisation, and then we're looking at capacity building, we're looking at improving community involvement, a stroke register, and then a 4th initiative to try and identify something that can be delivered by non-medical staff. So very similar, listening to the previous speaker, the stroke pathway is not as established as in the UK, and there are very few rehab professionals. There are some physiotherapists, and there's a initiative to start training physiotherapists. The BSc's started, but no occupational therapy, speech therapists, or clinical psychologists attached at the moment. Okay, next one. Okay, so community engagement has done extremely well. People have worked really hard on that, noticeably Jess O'Hara. And this was based on something we started with the South London Register, and Professor Chris McKevitt was the person who initiated this. So a group of stroke survivors has been established And the idea is that they will provide a panel to comment on the study from the service user point of view. So they've been meeting regularly and comment on things like outcome measures, but also share their experience of stroke. What we're hoping is that this group of people carry on this initiative once the study is over. So part of what we're trying to do is to empower the stroke survivors to continue a group on their own, and we will try and find some form of funding for that. If anyone's got any suggestions, we'd be very grateful for them. Okay, thanks. Okay, over to you, Dan.
Good afternoon to everybody. So just to talk through one of the aspects of the stroke in Sierra Leone research, which alludes to the research gap and the lack of evidence that Rufus indicated in his first talk. So for over 12 months now, we've been supporting a prospective longitudinal hospital-based stroke register at Connaught Hospital, which is the principal hospital in Freetown, and are now collected close to 500 participants. And we're trying to keep the register and the data collection going through these troubling times of COVID-19. So maybe just to provide you a very quick snapshot of the data that is being produced on stroke patients in Sierra Leone. And what you can see as you look at this table is you can see that relatively young people are having strokes, that the majority of people, 82% of people attending, are attending with their first stroke. As other studies on the continent have shown, hypertension is one of our principal risk factors. And this below is the median stroke severity score. And this is a severity score of 17, which is quite high. But probably the most important thing to take away from this slide is about function and the effect these strokes are having on people's lives. So the median Bartel index, the function of people before they have a stroke, is 100. And then after stroke, their Bartel index is dropping down to 15. So we're showing at the moment a hemorrhagic stroke prevalence of 29%. And so what happens to these stroke patients when they come to Connaught? What are the processes of care? So at the moment, people are staying for around 9 days. The 87% are receiving a CT scan. 65% of patients are receiving a statin. And only 60% are receiving a referral to a physiotherapist. And out of that 60%, only 2/3 are then able to have an appointment with a physiotherapist whilst in hospital. We're seeing a high in hospital mortality of 36%, and a quarter of our patients are being diagnosed with pneumonia or aspiration pneumonia whilst in hospital. And overall, out of all the patients, 41% are having at least one complication. This slide just looks at follow-up, as we follow up to have quite a high follow-up rate. So 95% of all of our participants have been contacted at 90 days. And what that's shown to us is that, again, a high proportion are dying after their discharge from the hospital. And also many patients are reporting new symptoms, whether that's visual symptoms, weakness, or speech after discharge. And less than a quarter of those who are having new signs of stroke sought care again. And again, those who have received physiotherapy post-discharge is very low. So that's a quick snapshot of the register data. I'd like to move on now and show you two graphs which talk about the impact of COVID-19 on both stroke health-seeking behavior and stroke severity. So this graph shows the number of stroke patients who are being admitted into the hospital per month, and the time it takes for patients who are suffering from stroke to present at the hospital. So if you look along the bottom axis, you'll see 12 months of data from April 2019 until April 2020. And if you concentrate on the dark blue line, you'll see that there's a drop-off around March 2020. So at the beginning of March 2020, Sierra Leone started to implement quarantine of individuals coming from airports. There was closing of borders and other measures to try and stop the spread of coronavirus. And then on the 31st of March was the first case in Sierra Leone. So you see there's a large drop-off. So the number of patients coming to the hospital has halved. And we also see that during March, when many of the lockdown procedures were implemented, there's a large increase in the amount of time taken for a stroke patient to present at a hospital. This is the second graph. Again, this shows changes over time with 1 year, 1 year's data from the register. And what we can see as we look at March 2020, in the light green line, we can see that in-hospital mortality has increased, and that's gone from around 35% up to over 50%. And during that time, we haven't seen much of a change in stroke severity. So I'd like to conclude with that we're seeing, here in Sierra Leone, we're seeing the impacts of coronavirus impacting on both health-seeking behavior for stroke, but also impacting the service availability and potentially the quality of care that's been offered to patients. And I think that just underlines the need for all of us to maintain and strengthen essential stroke services during these times, and hopefully build back better for stronger stroke services in Africa. Thank you.
Thank you very much to Kath and to Dan for those insights from the Sicily project. I think, you know, what really is resonating is the impact of stroke on people's lives in the context of Sierra Leone, but the incredible work that you're doing to add to the data of the burden in Sierra Leone, and really interesting to hear about the impact of COVID-19 on health-seeking behaviour and quality of care. So thank you to the CISO project. We're now going to bring in our third panellist, Dr. Gerard Urimubenshi from the University of Rwanda and the OSCAL project, so the Organised Stroke Care Across Income Levels study. So Dr. Gerard is a physiotherapist. He holds the PhD in cardiovascular sciences from the University of Glasgow and a master's in physiotherapy from the Western Cape University in South Africa. His postgraduate studies focused on stroke services and patient outcomes. Gerard was the country champion for the OSCAL study in Rwanda from 2017 to 2019. He's now the head of the local committee for improving stroke care and outcomes in Rwanda. And from 2011 to the present, Gerard is on the academic staff in the Department of Physiotherapy at the University of Rwanda. His current interests are building research capacity and partnerships for stroke service improvement in low-income settings. So I'll hand over to you, Gerard. Thank you.
Thank you, Sarah, for introducing me. And as you said, I'm going to talk about a study called Organized Stroke Care Across Income Levels, OSCE in abbreviation. The study was developed by a group of investigators and is being conducted in 4 countries: South Africa, India, Uganda, and Rwanda. And the study is being funded by the Population Health Research Institute from Canada. So I would like to start with, Jackie. I would like to start with a background information about stroke in Rwanda. And the available information indicates that stroke is, we're having issues with control. Jackie, can you let me do it myself? Okay. Jack, we're having issue with remote control. Okay. What's the problem? The available information indicates that stroke is among the top causes of deaths with a very high mortality rate of over 80 per 100,000 population. And more than a quarter of admitted patients die in hospital. And in 1 year after stroke, the majority of patients are dead or left with significant disability. Despite the burden of stroke, there is no organized stroke care in Rwanda. Yes. So as I said, the organized stroke care is being conducted in 4 countries: South Africa, India, Uganda, and Rwanda. And the aim is to test whether stroke services and patient outcomes can be improved by training and supporting the low and middle income country settings. To achieve our aim, we used a before and after implementation trial, and we aimed to recruit 70 patients per site and per phase. So we had 2 phases: observation phase and intervention phase. In intervention phase, we conducted a training, but also provided feedback on the result we had from the observation phase. And we had meetings with hospital directors and used site champions to see if stroke services can be improved. Okay, so in our audit and training, we considered the commonly reported key performance indicators for quality stroke care, from brain imaging to admission, drug therapy, then rehabilitation and discharge planning. And all these key performance indicators covered the whole patient pathway. Now I'm going to talk about the results we had in Rwanda from the OSCE study. So we collect data on a wide range of variables, but this short presentation is going to focus on a few of them. So regarding age and sex, there was a quite similar distribution at both sites, and for the 2 phases, observation and intervention. But when it comes to stroke types, there was a significant difference at one site, whereby during the observation phase, we had more ischemic stroke cases, while during the intervention phase, the hemorrhagic stroke was more common. So as I said, after the audit, we organized a training seminar to see if stroke services can be improved. The attendance to the seminar was excellent and multidisciplinary, whereby medical doctors, nurses, physios, and other healthcare professionals were all brought together to be trained on organized stroke care. And we were able to cover the common stroke key performance indicators. The pictures you see illustrate the seminar format, the meetings you had with the key local stakeholders and the multidisciplinary team that attended the training seminar. Sorry for this, we have problems because we tried a remote control, but we are having challenges, sorry for that. So I would like to say that after the intervention, we observed a consistent trend of absolute increase in the number of patients who received stroke key performance indicators, and the increase was statistically significant for most of the key performance indicators investigated. However, for some variables, we could not find a really statistically significant improvement. For instance, for antithrombotic therapy for those with ischemic stroke, we did not find a significant change, but also surgical intervention for intracerebral hemorrhage, as well as sugar and blood pressure lowering therapy. We did not find a significant improvement. Regarding the patient outcomes, we found about 8% also decrease in case fatality in hospital, and about 70% also decrease in case fatality at 3 months post-stroke. The result also indicated that there is an improvement in patients with better outcome, because we found that patients with poor outcome decreased, and the decrease was about 14%. So as conclusion, as take-home message, I'd like to say that training and supporting local staff on stroke key performance indicators can result in improved services and possibly patient outcomes. However, a larger study is required to implement a more structured and sustainable program. As a way forward, the local clinicians, researchers, and policymakers, in collaboration with the OSCARE investigators, developed a wider and similar project to improve stroke services and patient outcomes. And the project will focus on 3 main activities, including understanding the burden of stroke in Rwanda, and organizing a multidisciplinary specialized educational training to care for post-stroke issues and research determine the effectiveness of stroke interventions in Rwanda. So building on ISCO, this and experience we had from OSCARE, we had organized a symposium about stroke in the first half of 2020, but because of the COVID-19, we are obliged to wait when the restrictions will be lifted and schedule the symposium date again. And we also think that we may have difficulties to get the funds we need for all the school activities because of the financial crisis caused by the COVID-19 pandemic. So with this, I would like to say thank you and sorry for the challenges we had with the presentation.
Thank you very much, Gerard, and well done for managing the technical difficulties. We thought we might lose you, but instead the slides didn't quite work how you wanted them to. But that's absolutely fine. Your presentation was really clear. And what we can do is, if it's okay with you, we can include the slides on the WSO website so people can take a closer look as they listen to the recording. So thank you to all of our panelists. We recognise how important your insights are to our understanding of the burden of stroke across sub-Saharan Africa, and your work to research and add to the data and identify ways to improve stroke outcomes across the continent. We've had a number of questions in. I'll kick off, I think, with some that are actually directed to you, Rufus, around the African Stroke Organisation, and a number of people have commended you on your presentation, but they would also like to know how they are able to make contact with the African Stroke Organisation and become a member.
Right, thank you very much, Sarah. Many thanks to the comments from esteemed colleagues from across the continent and outside Africa. Yes, it is indeed possible to join the African Stroke Organization, either as a regular member or as an associate or as a junior member for those who are in training. I would suggest that at the moment, we're developing the website for the organization, but at the moment, there is an email address that I did show on that slide where I gave a rundown on the activities of the organization. African Stroke Organization at gmail.com. If you do send an email to that email address, we do have a Google a link to a Google document, a Google form that serves as a registration platform at the moment. And it is just through that platform that we'd had about 180 people who have registered so far. So it's possible. Of course, when the website is ready, then people can just go to the website and then click register. Thank you.
That's great. Thank you, Rufus. And we will also, we can share the link on the WSO website so to direct people to the African Stroke Organisation. So I have a couple of questions for the CISLE team, and I appreciate that Professor Radcliffe-Lisk may also want to come in to answer some of these questions alongside Dan and Kath. So I'll bundle them together and perhaps direct them firstly to you, Kath, and you can signpost to Dan or Professor Radcliffe. So the first question is data from the stroke register influencing government spend for stroke service development in Sierra Leone? I appreciate this is what I'm going to add to this. It may be a little early to start using some of the data for advocacy, but perhaps you could highlight to us how you might be planning to do that in the future. And there's a second question directed to you, Dan, and perhaps to you, Professor Radcliffe, about what measures you are considering to resolve the barriers that you've identified. And a third question, let me see. I'll leave it there now for CISLE, but I'll come back to you.
Okay, so I'm just going to say it is too early with the data. It's not been cleaned or analysed formally yet. We're giving a snapshot of what we're finding. But I'm going to hand over first to Dan to talk about the influencing work at policy level that he's done.
Okay, so I think some of this pilot data has been shared with the Directorate of Non-Communicable Diseases in Sierra Leone, who are in the process of developing a new strategic plan to address the rising burden of NCDs, including stroke. And I think this data, alongside the work of Propolis over the years, has really helped make the focus of that NCD plan be on tackling hypertension and stroke care being mentioned for the first time as a clinical service to focus on. Prof, do you have more to add?
Yes, actually, I think as far as the ministry is concerned, we need to get them to emphasize on blood pressure control and management, and also on trying to improve the knowledge of patients regarding blood pressure. There are a few work that has been done. In fact, there's a publication probably due to come out soon where myself, Dr. Russell, looked at blood pressure of health workers at Connaught Hospital. So hypertension and knowledge of hypertension on health workers at Connaught Hospital. And it showed that even among the health workers at Connaught Hospital, which is the main tertiary hospital, there is quite a lot of a lot that needs to be done in terms of improving their knowledge, and also for them to know exactly what to do to try and reduce the prevalence of hypertension. So I think what the ministry would probably start doing initially is to try to reduce risk factors. And that has to be done by sensitization, which I don't think we're having enough of. There are so many people who just do not know what to do with regards to blood pressure management, with regards to regular checks of blood pressure, blood sugar, smoking, etc. So perhaps that is one area that can be tackled right now, even without the results of this study. So we have to lobby the ministry and also other non-governmental organizations to prioritize the spread of knowledge among the population at large, among the communities, on stroke risk factors and how to reduce them. I think this by itself would have an impact on the prevalence of stroke, and also on the way that people regard stroke in terms of accessing hospitals rather quickly, rather than wait for a few days before they go to hospital, by which time it may be too late.
Great, thank you all. I realised there was quite a few questions for the Sicily project, and Dan is extremely efficient and has answered them, most of them in the chat function. So, sorry, in the Q&A function. So if anyone has posted a question, Dan has answered a number of them in the text box. So I have a question here from Ingrid in South Africa. And I'm going to direct this to Gerard. So in Pretoria, South Africa, we find that individuals feel that they are the only one that has had a stroke and survived, and are amazed when they find a support group where others have the same problems and where they find support and advice. My personal opinion is that students, medicine and supplementary, so physio, OT, speech therapy, should be educated regarding the importance of stroke groups, support groups for stroke. Stroke survivors supporting each other and being supported is an ongoing manner by professionals and other interested people to live fruitful and social lives. And so the question really is, has this education for allied professionals about long-term stroke support groups, has it happened elsewhere across Africa? And I know, Gerard, we've previously had some discussions about raising awareness of the role of stroke support groups. Gerard, did you hear that question? Okay, I think we might have lost Gerard, but what I'll do, Ingrid, is just talk through some of my experience of this within sub-Saharan Africa and how I am making connections between scientific, professional societies and linking them to the stroke support organisations that I am aware of. And I know through the African Stroke Organisation, there has been a real impetus on ensuring that that organisation is made up of a range of different stakeholders involved in stroke support. So clinicians, researchers, stroke survivors, and people who are leading stroke support organisations. So we hope through that platform as well that there might be greater linkages between allied professionals and stroke support organisations. So there is also another question around collaboration, and I think it came across very strongly in Dr. Akinyemi's presentation about collaboration. And I just wondered, from the CISLE project and from the OSCAL project, whether you have seen opportunities to increase the collaboration of your particular research area and your particular location with other areas or other countries in sub-Saharan Africa, because I guess the risk is that research projects are happening in silos, in an isolation, which makes it much more difficult to elevate the profile of the range of different research projects and initiatives that are going on across the context, both, across the continent, and also to elevate that beyond Africa into international forums. So my question is around opportunities to collaborate more and where you would like to do this more or are planning to do this more.
I would just like to say how great this has been today and extremely useful. And although I knew people, I've learned much more about what they've been doing. And I find these networks have gradually developed around other stroke groups like the UK Stroke Forum, like the meeting in Vienna, which unfortunately didn't go ahead. So just to thank you from me for organising this today.
Sorry, Dan or Professor Radcliffe, have you got anything else to add around collaboration and elevating the profile of research that's going on across countries in sub-Saharan Africa?
I think some collaboration has been going on. In the Siren studies, they had quite a few centers in Ghana and Nigeria collaborating in that study. But I think we need more of this. And I think the main problem has been funding. Because what happens that every institution has a little bit of funds and then they do their own research. I mean, to do cross-institutional research, I think you need greater funding opportunities to get people together. And we just hope that in time this will happen, because it's definitely the next step. And I think we should try and make it happen.
Yes, if I may add again that in addition to the Siren collaborations across 15 centers in Nigeria and Ghana, we had previously collaborated on the tribes trial, which is actually a secondary prevention trial. And then currently, a number of centers in Nigeria, about 7 centers, are collaborating on the ongoing Trident trial, which is a multinational trial that is led by a group from Australia. So Nigerian centers are working with partners in other countries on this trial. And I would say that, yes, Africa is ripe for multi-center and multinational collaborations. We have experience in the SIRI project, which we're happy to share, and we certainly hope to do this using the platform of the ESO to share our experiences in collaboration. Thank you.
Great, thank you, Rufus and Kath. I think this question is very pertinent at this time, and I know, Rufus, you've sought to answer this in the text Q&A, but I think it would just be interesting to hear from others around how can modern communication technology help to reduce the stroke burden in Africa, since time is of the essence in limiting disability and mortality. And so I just wonder, from your own work and also in the current context of COVID-19, have you seen any particular innovations that you think we should hold on to this and ensure that this is part of, as Dan had previously said, about building back better? So perhaps I'll direct that to Dan, and perhaps Gerard, you could also come in.
Yeah, thank you very much, Sarah. From our experience with the TRIBES trial, we did have, as part of our intervention package, sending SMS messages to the intervention group. We did have a 5-minute video which we showed them whenever they came to the clinic. Now, what we found out was that 100% of participants on this trial did have mobile phones, so they were able to receive our messages. Also, our colleagues again in Ghana on the PINKS trial have also demonstrated that it is actually feasible to now reach our patients through text messages and of course through WhatsApp. And in my center here in Ibadan, since the advent of the COVID-19 pandemic, we've had to innovatively start reaching our stroke patients and other neurology patients through WhatsApp, and of course, the hospital has a telemedicine unit that reaches out to the patients. So telemedicine is now alive and active here in Ibadan, and I'm sure that this can be done across all African sites because virtually everybody now has a mobile phone. And if we're able to do this, we can send messages on stroke prevention. We can set up a stroke alert system, which actually tried to do in a recently funded NIH study that we call ARISES. We're going to be using a stroke alert system to pick cases of stroke in demographic surveillance sites of that study. So I think that it is feasible indeed in current day Africa. And of course, it's cheaper, you know, if we're able to incorporate these into our stroke care packages. Thank you.
Thank you, Rufus. And Gerard, would you like to add to that?
Yes, first of all, let's talk about the previous discussion. As I said, we do need to have organized stroke care in our country, and the study we did was only on the 2 centers. We think for the next step in our next project, we need to expand our activities and try to develop multidisciplinary teams for stroke care in other settings in our country. And for that, we need to have platforms for network and sharing experiences at national level, but also in Africa and international level. And as Rufus presented, having a national stroke organization collaborating with the African one and World Stroke Organization, I think we can improve things at each of the 3 levels. Coming to the use of technology for stroke care, for instance, one of the challenges we do have in our country is rehabilitation post-discharge. Patients, when discharged, they do not have, there is no follow-up, there is no community-based rehabilitation, they stay at home, and it's difficult for them to come back to hospitals for outpatient rehabilitation. I think, as Rufus said, can use technology like mobile phones. And there's an opportunity in our country that very soon we're going to have like a smartphone per family that will help to design exercises, for instance, for post-stroke rehabilitation. I think there is a room for technology now to advance rehabilitation services in our country, but also other services as well. Just rehabilitation was an example.
Yeah, thank you, Gerard. And I think, you know, we're seeing much more now in a range of different contexts, both the higher income and lower income contexts, of people using mobile technology to support long-term care and rehabilitation activities. So I think that there will be an awful lot of learning to share from across the global network of people involved in stroke care. And certainly I know that there's a number of initiatives around telehealth. I would encourage people to watch the previous WSO webinar on telehealth, and a number of initiatives that perhaps could inform activities within sub-Saharan Africa. Now, I recognise we're now at 3:10, and there is still a number of questions to answer. So my suggestion is that we close now, but that we carry over some of the questions to our tweet chat, which will be happening on the 10th of June. But also, as we've done in previous webinars, we've answered the questions offline and then posted them on the WSO website. So rest assured, if you've posed a question and it hasn't been answered, we can go back to the panelists and ask them to answer the questions offline. So firstly, or lastly, I just want to say thank you so much to all of our panelists from across Africa and from within the UK, and also Jackie, who was in support from Canada. It was a pleasure to host this webinar. We are in having initial conversations with the African Stroke Organisation to continue to host some joint World Stroke Organisation and Africa Stroke Organisation webinars. There's clearly an appetite for these webinars and a focus on stroke care in Africa, but also we recognise that we've only scratched the surface and there's an awful lot of work and context to uncover and to share as much as we can. So I'd like to say thank you to you all for joining, and we're pleased that we were able to facilitate the connections from Sierra Leone and Nigeria and Rwanda. So thank you all, and have a great morning, afternoon or evening. Bye for now.